I'm about to reveal something that might completely change how you think about your blood pressure and your sleep. Something about what is happening inside your body every single night between 2 and 3 in the morning while you are completely asleep and have no idea it is happening. Something about the reading your doctor takes at 10 a.m. that looks perfectly fine and means almost nothing. Because there is a very high chance that the blood pressure your doctor has been managing is not the blood pressure that is actually killing you. The one killing you happens in the dark, when no cuff is on your arm and no one is watching. Most doctors never look for it. Most seniors never know it exists. But the research on this is unambiguous. And by the end of this video, you will understand exactly why blood pressure spikes at 3 in the morning in people who do everything right. The 6 specific mechanisms driving it, including one that has been misdiagnosed as a prostate problem for decades, and the 4-part nighttime protocol that stops it. This isn't about changing your medication. This is about understanding what your body is actually doing while you sleep. Because what you're about to learn could be the most important thing you've ever heard about your heart. Stay with me, because this starts with a man named Walter. Walter was 73 years old. He lived in Baton Rouge, Louisiana. He was the kind of man who had taken care of himself his whole life. Not obsessively, but steadily. The way a person does when they understand the value of what they have. He walked every morning. He watched what he ate. He had been on a single blood pressure medication for 6 years, and his readings at his doctor's office were consistently in the range his cardiologist called good. 128/78, sometimes better. His doctor told him at every appointment that he was managing this well. Walter woke up at 3 in the morning almost every night to urinate. Had for years. He mentioned it to his urologist, who told him it was a common consequence of an enlarged prostate and age-related bladder changes. He was given a medication for it. It helped slightly. He accepted this as the reality of being 73. He also woke every morning with a dull heaviness behind his eyes. Not a headache exactly, a pressure. It was usually gone by the time he had his coffee, but it met him at the edge of every morning, and he had learned not to mention it because every time he did, someone told him it was stress or dehydration or aging. He believed them because they were doctors and he was not. What nobody had told Walter, not his cardiologist, not his urologist, not anyone, was that the 2 o'clock bathroom trip and the morning pressure behind his eyes were the same event. Both were symptoms of a blood pressure crisis happening inside his body every single night. A crisis that his 10 a.m. reading at the doctor's office was completely invisible to, because by 10 a.m. it was over. His blood pressure at 3 in the morning was 168/97. He had never measured it. His doctor had never asked him to, and so it went undetected for 6 years, while his arteries absorbed the damage every night after night, in the hours when nobody was looking. His wife Patricia had noticed things he had stopped registering. The way he moved from the bedroom to the bathroom in the dark, cautious, one hand on the wall, the careful shuffle of a man who had learned that moving too fast in the night could make the room tilt. The way he sat on the edge of the bed for a moment before standing, every morning apparently gathering himself. She had asked about it once, early on. He told her it was nothing, just getting older, and she had accepted this because he was not a man who complained, and she trusted his judgment about his own body. She had also noticed that he woke up looking tired, in a way that sleep was not fixing. Not the normal tiredness of a man in his 70s, something heavier. She used the word depleted when she mentioned it to her daughter, like he was starting every day already behind. Walter himself had learned to work around the symptoms so smoothly that he had stopped recognizing them as symptoms. He had moved a lamp to the bathroom so he would not have to navigate in complete darkness. He had put a glass of water on his nightstand. He had quietly stopped making plans for early mornings because he found that the first 2 hours of the day required more effort than they used to. He was compensating continuously for a problem he did not know he had. His general practitioner had run a full metabolic panel, a lipid panel, a thyroid screen, and a kidney function test at his last annual physical. Everything was normal. His doctor told him he was in excellent health for his age, and that the morning fatigue was likely a combination of natural sleep changes and the demands of managing a chronic condition. He said this with genuine care. He believed it. The chart said Walter was healthy. The chart was right about the measurements it had taken. But nobody had taken measurements between 2 and 4 in the morning. Walter's daughter, who worked in healthcare administration, had read something about ambulatory blood pressure monitoring and mentioned it to him. He brought it up at his next appointment, somewhat apologetically, the way a patient raises something they found online when they are not sure if they are wasting the doctor's time. His cardiologist ordered it without hesitation. He said he should have ordered it years ago, given the nighttime symptoms. Walter wore the cuff for 24 hours. It inflated every 30 minutes during the day and every hour through the night. He barely noticed it during the day. At night, the inflation woke him slightly each time, a soft squeeze, then release, but he went back to sleep easily. When the report came back, his cardiologist called him directly rather than waiting for the next appointment. The nighttime readings were the story. 168/97 at 3:14 a.m., 172/99 at 3:41 a.m., 165/94 at 4:08 a.m. His daytime readings, taken by the same device on the same day, averaged 126/77. The gap was not subtle. It was not a borderline finding. It was a nightly crisis that had been invisible for 6 years because the only time anyone had ever measured his blood pressure was when he was sitting in a clinic in the middle of the morning. His cardiologist said, "We have been managing the wrong reading. These nighttime numbers are the ones determining your cardiovascular risk, and we need to talk about what is causing them." Walter had what cardiologists call a reverse dipping pattern, and understanding what that is and why it happens is what this video is about. In a healthy body, sleep is not passive. When the eyes close and the brain begins its descent into deep sleep, the nervous system shifts from sympathetic dominance, the fight or flight wiring that runs the body during the day, to parasympathetic dominance. Heart rate drops, breathing slows, and blood pressure falls, consistently, by 10 to 20% below its daytime level. This is called the nocturnal dip, and it is not a side effect of sleep. It is one of sleep's primary biological functions. That 10 to 20% drop is the only window in a 24-hour cycle when the endothelial lining of the arteries, the thin, exquisitely sensitive inner wall of every blood vessel in the body, gets to genuinely rest. Micro tears heal. Oxidative stress clears. The vascular system recovers from the mechanical load of a day of circulation. The nocturnal dip is not optional maintenance. It is the nightly repair cycle that determines whether your arteries age fast or slowly. The implications of this are worth sitting with for a moment, because they fundamentally change how to think about blood pressure management for seniors. Your doctor's appointment is almost always in the morning or afternoon. The reading is taken after you have been sitting for a few minutes. It is calm, controlled, reproducible. It is the number that goes in your chart, drives the medication decisions, and defines your risk profile in the medical record. And for a non-dipper or reverse dipper, it is the reading that most significantly underestimates what is actually happening to your arteries. The arteries do not care about the 10 a.m. reading. They are absorbing whatever pressure they experience across every hour of every 24-hour cycle. The nightly repair window, the nocturnal dip, either happens or it does not. And if it does not happen for years, the accumulated damage is real, regardless of how clean the chart looks. When that dip does not happen, when blood pressure stays flat through the night, or worse, rises, the repair cycle never runs. The arteries accumulate damage without recovery, night after night, year after year. And the clinical data on what this produces is not ambiguous. The Dublin Outcome Study and the Framingham Heart Study both demonstrated the same thing. Nighttime blood pressure is a significantly more accurate predictor of cardiovascular death than daytime blood pressure. A senior with a perfect 128/78 at their 10 a.m. appointment, who is a reverse dipper hitting 165/95 at 3 a.m., carries a risk profile that their doctor has never seen and their chart has never captured. And the most dangerous consequence is specific. It has a name. Cardiologists call it the 6 a.m. stroke. The 6 a.m. stroke is not a medical metaphor. It is a documented, reproducible pattern that appears in stroke registries across every country where data has been collected. Emergency departments know it. Neurologists know it. The 6 to 10 a.m. clustering of stroke admissions is one of the most consistent patterns in cardiovascular emergency medicine. The mechanism is mechanical and brutal. The blood vessels of the brain are not uniform in their resilience. They have weak points, small perforating arteries, tiny bifurcations where pressure concentrates, areas where decades of flow have created micro-damage that the nocturnal repair cycle was supposed to address. In a reverse dipper, that repair cycle never ran. Those weak points accumulated damage rather than healing it. Night after night, the arteries absorbed 170/100 for 2 hours, instead of dropping to 108/65 and resting. By the time the alarm goes off at 6 a.m., those vessels are at the limit of what they can hold. And then, the body's normal morning activation fires. Cortisol surges, adrenaline is released. Blood pressure, which was already elevated from the nighttime mechanisms, rises sharply in the first minutes of getting out of bed. The combination, structurally compromised vessels meeting a sharp morning pressure surge, is what the stroke registries show in the data. Not random, not unlucky, predictable, mechanically, for any senior with the reverse dipping pattern. Walter's morning heaviness behind the eyes was his brain telling him, in the only language it had, that the pressure had been high again, that the repair had not run, that the vessels were tired. He had been receiving this signal every morning for years and had been told it was aging. Strokes are not randomly distributed across the 24-hour clock. They cluster in the early morning hours, between 6 and 10 a.m., with a frequency that is far beyond chance. The reason is mechanical. The blood vessels of the brain have been under elevated pressure all night. The repair cycle did not run. The walls are weakened, and then the alarm goes off. The person sits up, stands. The sympathetic nervous system surges, flooding the body with adrenaline, driving blood pressure up sharply in the first moments of waking. The weakened vessels, battered all night, meet that sudden morning surge, and some of them fail. This is not rare. This is the most common timing of stroke in seniors, and the reverse dipping pattern is a primary driver. Now let me tell you exactly what causes it. Because there are 6 specific mechanisms, and most seniors who have the pattern have multiple running simultaneously. The first one has been misdiagnosed in urology offices across this country for decades. Walter's 3 a.m. bathroom trips were not caused by his prostate. They were caused by his heart. Here is the mechanism. When blood pressure spikes during sleep, as it does in a reverse dipper, the physical pressure inside the renal arteries feeding the kidneys reaches a crisis level. The body, which has extraordinarily sensitive pressure monitoring systems, recognizes that if this pressure is not reduced immediately, a blood vessel in the brain will rupture. So it activates an emergency pressure release valve. The kidneys receive a signal to aggressively filter water out of the bloodstream. Not gradually, the way normal kidney function works, rapidly. The goal is to reduce overall blood volume, which reduces pressure, which protects the brain. This process is called pressure natriuresis, and it is one of the body's most powerful acute blood pressure defense mechanisms. The water that gets pulled from the bloodstream has to go somewhere. It fills the bladder. Rapidly. The senior wakes up at 2 or 3 in the morning with an urgent need to urinate, shuffles to the bathroom in the dark, empties the bladder, and goes back to bed. The bladder is not the problem. The prostate is not the problem. Pressure natriuresis just fired to prevent a nighttime stroke. The full bladder is the receipt, evidence of a blood pressure crisis that is now resolved. This mechanism has a clinical name that almost nobody outside nephrology knows: pressure natriuresis. And the reason it matters beyond the immediate relief it provides is what it reveals about the severity of the pressure episode that triggered it. The kidney does not activate pressure natriuresis at 130/80. It activates it at pressures that constitute a genuine acute threat to the cerebral vasculature. The urgency of the drainage, the speed with which the bladder fills, the forcefulness of the need to urinate, is proportional to how severe the spike was. A gentle, gradual urge at 3 a.m. is different from the urgent, sudden need that wakes a senior out of a sound sleep. The latter is a more serious alarm. Urologists treat the bladder. The blood pressure crisis goes untreated. Walter's prostate medication did help slightly, because it mildly relaxed the urethra and made the urination less uncomfortable. but it did absolutely nothing for the 168/97 that was triggering the event in the first place. 6 years of treating the symptom while the cause operated uninterrupted. The second mechanism is the reason that a low-sodium diet works beautifully for some seniors and fails completely for others. A 30-year-old eats a salty lunch, and their efficient kidneys, running at high filtration capacity, clear that sodium from the blood by late afternoon. It is gone before dinner. But a 70-year-old's kidneys have stiffened filters. Their glomerular filtration rate has declined. They eat that same lunch, and their kidneys cannot clear the sodium during daylight hours. By 10 p.m., when they go to sleep, the bloodstream is still loaded with the salt from lunch. The body needs to clear it, but the stiff filters cannot do it at normal pressure. So the body takes a calculated decision that is devastating for the arteries, but necessary for the kidneys. It intentionally spikes blood pressure during the night. The elevated pressure physically forces the stubborn sodium through the stiffened renal tubules. The body is using the arteries as a hydraulic pump, sacrificing their long-term health to get the kidneys to do their job. The senior sleeps through this. The blood pressure climbs into the 160s. The arteries take the load. And in the morning, the sodium is gone. The blood pressure is back to 128/78, and the doctor's appointment at 10 a.m. shows nothing. The third mechanism does not require a sleep apnea diagnosis to trigger. This is the one that surprises people most. Normal aging causes a gradual loss of muscle tone throughout the body, including in the throat. When a senior lies down and falls asleep, the airway narrows slightly, not dramatically, not enough to cause the loud snoring and gasping of severe obstructive apnea, just narrowing, shallow breathing, a slight reduction in the efficiency of each breath. Blood oxygen saturation drops by perhaps 3 or 4%, a small number. But the kidneys are the most oxygen-sensitive organs in the human body. They monitor oxygen levels with a precision that no other organ matches. And when they detect even this small drop, their ancient biological programming activates a threat response. The assumption, hardwired across millions of years of evolution, is that a drop in blood oxygen means the body is bleeding out or suffocating. The kidneys release an enzyme called renin into the bloodstream. Renin triggers a rapid cascade that produces angiotensin II, one of the most powerful blood vessel constrictors in human biology. The arteries clamp down. Blood pressure surges into the 160s or 170s. The body is fighting an emergency that does not exist. The senior never wakes up. They continue sleeping. Dreaming, perhaps. While their blood pressure runs at 170/100 in response to a 4% oxygen drop that happened because they are sleeping on a normal aging throat. I want to make this mechanism viscerally clear because it is the one most seniors find hardest to believe. The idea that a 4% oxygen drop, barely perceptible, not enough to wake you, not enough to cause any symptoms you would notice, can trigger a blood pressure surge into the 170s seems disproportionate. But the response is calibrated for survival scenarios, not for quiet suburban bedrooms. The kidney's renin response evolved to handle genuine emergencies. A 4% oxygen drop in the ancestral environment meant significant hemorrhage or near drowning. The body had to act immediately and powerfully to preserve perfusion to the brain. The renin-angiotensin cascade is not a gentle nudge. It is an emergency lever. Angiotensin II is one of the most potent vasoconstrictors the body produces. The response is designed to be fast and overwhelming, because in the scenarios it evolved to address, slow or moderate responses meant death. The modern senior, lying in a climate-controlled bedroom with a narrowing throat from normal aging, is triggering this system with a signal that the body's programming cannot distinguish from catastrophic blood loss. The response is identical. The blood pressure surge is identical. The only difference is that there is no hemorrhage, just a slightly narrowed airway producing a slightly reduced oxygen reading in kidneys that cannot tell the difference. This is why addressing the airway, even gently, even without a CPAP machine, even just with nasal breathing that keeps the nitric oxide buffer active, matters so much in this specific pattern. You are not treating sleep apnea. You are interrupting the false alarm. No CPAP needed to trigger this. No diagnosis, no warning. Just the entirely normal narrowing of an aging airway, misread by a kidney that does not understand the difference between minor airway narrowing and catastrophic blood loss. The fourth mechanism is visible. You have likely seen it every evening without understanding what you were looking at. By the end of the day, most seniors have mild swelling in their lower legs. Not dramatic, not medical emergency swelling. Just the quiet, familiar accumulation of fluid that gravity pulls into the calves and ankles over hours of sitting and standing. The slight tightness in the shoes by late afternoon. The faint indentation from the sock. This fluid, sometimes approaching a full liter, does not stay there when the body lies flat. Gravity is removed. The fluid redistributes. Over the first 2 to 3 hours of sleep, it shifts from the legs back into the central circulation. The heart, which had been pumping a certain blood volume, is suddenly asked to handle significantly more. The blood volume expands unexpectedly. Pressure rises to move the heavier, fluid-loaded blood. And at 2 or 3 in the morning, which is when this redistribution completes, the spike arrives. The senior wakes up. Or doesn't. Either way, the arteries are absorbing a pressure surge that was avoidable, driven entirely by fluid that had been sitting in their calves all day. Let me tell you about a woman named Beverly to make the fluid shift concrete. Beverly was 68 years old. She worked part-time as a librarian in suburban Chicago and spent most of her shifts on her feet, then sat for several hours at a desk reviewing cataloging requests. By the end of every workday, her ankles were visibly swollen. Not dramatically. She could press her finger into the skin above her ankle, and the indentation would hold for a moment before filling back in. She had mentioned this to her doctor years ago. He told her it was mild-dependent edema, very common in women her age, and that she should try to elevate her feet when possible. She bought a small footstool for under her desk. It helped a little. She did not connect this to her blood pressure because nobody had ever explained the connection. The swelling was a legs problem, in her understanding. Her blood pressure was a heart problem. They lived in different categories. What was actually happening? That liter of fluid sitting in her calves when she went to bed at 10 p.m. was not staying there. Over the next 2 to 3 hours, as she lay flat, gravity released its hold and the fluid drained back into her central circulation. Her heart, which had been managing a certain blood volume all evening, was suddenly handling significantly more. The right side of the heart, which receives venous return from the legs, was being asked to move a substantially larger volume. Pressure climbed. By midnight, it was elevated. By 1 a.m., it was high enough to trigger compensatory mechanisms. Beverly had never been tested with ambulatory monitoring, but she described her mornings to her doctor in terms that, in retrospect, fit the pattern precisely. The first hour of the morning was hard in a way the rest of the day was not. The coffee helped, but there was a period before the coffee where she felt that her head was not right. She had attributed this, as Walter had, to the universal explanation of aging. The 6 p.m. leg elevation changed her mornings within 2 weeks of starting it. Not because it was complicated, because it addressed the fluid before bed rather than trying to compensate for it after the damage was done. Before I get to the final 2 mechanisms and the complete protocol, I want to say something to anyone who recognizes Walter's story or Beverly's story in their own experience. If you wake at 2 or 3 a.m. regularly, if your mornings start with that pressure or heaviness, if your doctor has never tested your nighttime readings, the protocol in the description below is what gets your blood pressure under control at night, when it matters. The link is there. The 5th mechanism is one that punishes the seniors who are most medically compliant. The ones who take their medication faithfully, on schedule, every morning without fail. Many seniors take a diuretic. Hydrochlorothiazide is the most common, to help control blood pressure by reducing fluid volume. They take it in the morning. By 2 a.m., it has been metabolized. It is gone from the system. The pharmacological effect has expired, but the body does not simply return to baseline when the medication leaves. It rebounds. All day, while the diuretic was working, the adrenal glands were fighting it, producing aldosterone, the hormone that commands the kidneys to hold on to sodium and water, trying to reclaim what the medication was removing. The diuretic was winning that battle. But at 2 a.m., when the medication vanishes, aldosterone is still being produced at elevated levels. The opposition has won, and there is no longer anything opposing it. The kidneys go into aggressive sodium and water retention. Blood volume climbs rapidly. Pressure surges. The senior who took their medication exactly as prescribed experiences a rebound hypertensive episode in the middle of the night, specifically because they took it in the morning instead of the evening. The cruel irony of the aldosterone rebound is that it rewards medication non-compliance. A senior who occasionally forgets their morning diuretic does not experience the rebound because their adrenal glands never built up the suppressed aldosterone drive. The senior who takes their diuretic every single morning, without fail, for years, whose adrenal glands have been chronically stimulated to produce more and more aldosterone to fight the medication, experiences the most severe rebound when the medication window closes. This is not a reason to stop taking the medication. The diuretic is doing its job during the day. The problem is the gap. The nighttime gap between when the medication's effect expires and when the next morning dose begins is the window where aldosterone runs unopposed. The chronotherapy solution, moving one medication to bedtime, partly addresses this by maintaining some pharmacological activity through the overnight hours, reducing the gap during which aldosterone can dominate unchecked. The sixth mechanism is the reason that stress and sleep quality are not separate from blood pressure. They are the same thing, running on the same biological circuit. Cortisol follows a strict daily rhythm in a healthy body. It bottoms out around midnight, then climbs steadily, peaking just before waking to prepare the body for the demands of the day. This cortisol morning surge is part of what causes the sharp rise in blood pressure in the first hour after waking. And in a body with healthy nighttime cortisol levels, this is manageable. But in seniors with chronic stress, insulin resistance, or disrupted sleep, the HPA axis, the hypothalamic pituitary adrenal circuit that controls cortisol, loses its rhythm. Cortisol stops bottoming out at midnight. It stays elevated. It runs through the night at levels that belong in the morning. Cortisol at those levels suppresses melatonin, preventing deep restorative sleep. It keeps the sympathetic nervous system switched on, the fight-or-flight circuit running continuously in a body that is lying still in a dark room. And it makes the blood vessels hyper-reactive to adrenaline, so that any small trigger, a minor apnea, a position shift, the normal cortisol increase before dawn, produces a blood pressure spike that would not happen in a body whose cortisol was properly suppressed overnight. The body is biochemically fighting a war while lying completely still, and the arteries pay for it. The broken HPA axis is worth dwelling on because it connects to something most seniors understand from their own experience but rarely connect to their blood pressure. The feeling of lying awake at 3 a.m. with the mind running. The sense of being tired but not restful. The way that worrying happens at 2 in the morning in a way it does not during the day. This is not a personality trait or a weakness of the anxious mind. It is elevated nocturnal cortisol, keeping the sympathetic nervous system engaged in a body that needs the parasympathetic system to take over. Cortisol at midnight level elevations does not cause dramatic wakefulness. It causes shallow, unrestorative sleep. The kind where the body feels like it slept, but the brain does not feel like it rested. The kind where the dreams are vivid and exhausting, rather than soft and forgotten. The body thinks it is partially awake. The sympathetic system remains partially active. And the blood vessels, receiving continuous, low-level sympathetic stimulation, never fully dilate. The nocturnal dip never reaches its full depth, or does not happen at all. Walter's story did not end with the ambulatory monitoring report. It began there. His cardiologist moved his ACE inhibitor to bedtime. He started the leg elevation at 6 p.m. Patricia joined him, lying on the living room floor with her own legs up on the couch, which became, after the first week of mild awkwardness, something they did together without discussion. He began the nasal tape. He made no other changes. At his 1-month follow-up, the ambulatory monitor showed nighttime readings averaging 138/84. The 168 spikes were gone. The 3 a.m. bathroom trips, which had been nightly for years, dropped to 2 or 3 times per week. And when they happened, he went back to sleep easily rather than lying awake afterward as he often had before. His wife Patricia told him he looked different in the morning. He told her he felt it. 3 months in, he added the potassium dinner consistently. The remaining bathroom trips became infrequent. His cardiologist, at the 6-month appointment, reviewed the trend and said something Walter had never heard in 6 years of managing this condition. He said, I think we can discuss reducing your morning medication dose. Walter had not added a medication. He had not changed his diet beyond one meal. He had not done anything dramatic. He had addressed 4 specific mechanisms that had been running invisibly in his body every night for years, with 4 targeted interventions that required nothing more than timing, position, and tape. What changed was not his body. It was the information he had about what his body was doing. Now, 6 mechanisms, all of them invisible to the 10 a.m. cuff, all of them operating in the same 2-hour window. And in most reverse dippers, several of them are running simultaneously, stacking pressure on pressure in the dark. Walter had 4 of the 6. The pressure natriuresis told him every night through the bathroom trip. The delayed sodium excretion from his kidneys working the night shift. The fluid shift from the ankle swelling he had accepted as normal. And the aldosterone rebound from the diuretic he took every morning at 7 a.m. and was gone by 2 a.m. When he was finally referred to a practitioner who did ambulatory blood pressure monitoring, a small cuff worn for 24 hours that records readings continuously, including during sleep, the nighttime numbers were on the report in black and white. 168/97 at 3:14 a.m. 172/99 at 3:41 a.m. The pattern was unmistakable. His cardiologist looked at the report and said, "We have been managing the wrong reading." Now let me tell you exactly what addresses each of these mechanisms at the root. The first intervention is the one with the most dramatic clinical evidence behind it. The Hygia chronotherapy trial followed over 19,000 patients for years. The researchers found that simply moving at least one prescribed blood pressure medication from morning to bedtime reduced the risk of cardiovascular events, heart attacks, and strokes by 45%. Not a new drug, not a higher dose. The same pill taken at night instead of the morning, producing its peak effectiveness exactly when the reverse dipping window opens and the renin-angiotensin panic fires. Walter's case illustrates why this trial matters so much. His diuretic was correctly kept in the morning. His cardiologist understood that moving it would cause overnight urination that was worse than the problem being solved. But his ACE inhibitor, which had been taken at 7 a.m. for 6 years, was moved to bedtime. His cardiologist explained the rationale. The ACE inhibitor's peak inhibition of the renin-angiotensin cascade would now occur during the 3 a.m. window when Walter's kidneys were generating renin in response to the minor oxygen drops from his narrowed airway. The medication would be at maximum strength precisely when the trigger was firing. At his 1-month follow-up, Walter's ambulatory monitoring showed nighttime readings averaging 138/84. Not perfect, not down to the nocturnal dip range of a healthy 35-year-old, but the 168/97 spikes were gone. The 3 a.m. trips to the bathroom had reduced from nightly to 2 or 3 times per week. The morning heaviness behind his eyes, which he had lived with for years and stopped mentioning, was gone within the first week. His wife Patricia told him he looked different in the morning. He told her he felt it. One critical warning on this: if your diuretic is moved to bedtime, it will cause significant overnight urination. Many doctors specifically keep diuretics in the morning for this reason. The bedtime shift works best for ACE inhibitors, ARBs, and calcium channel blockers. Do not change the timing of any medication without discussing it with your doctor first. That conversation, with the words Hygia chronotherapy trial ready to reference, is worth having at your next appointment. Ambulatory blood pressure monitoring should be standard for any senior whose blood pressure does not respond normally to medication, who wakes regularly in the night, or who has morning symptoms that cannot be explained by the daytime numbers. It is not an exotic test. It is a 24-hour cuff. It is covered by most insurance when ordered with appropriate clinical justification. And the information it returns, the nighttime readings, the dipping pattern, the 3 a.m. window, is the information that actually determines cardiovascular risk in seniors. If you have been told your blood pressure is managed and you still have morning symptoms that nobody has explained, it is worth asking your doctor specifically about ambulatory blood pressure monitoring. Ask about your nighttime readings. Ask whether your dipping pattern has ever been evaluated. Those questions may open a conversation that daytime measurements alone cannot. The second intervention addresses the fluid shift and the delayed sodium excretion simultaneously, and it requires nothing but a wall and 20 minutes. At 6 p.m., not at bedtime, at 6 p.m., get into a recliner and kick it all the way back, or lie flat on your bed or sofa with 2 or 3 pillows stacked under your calves so your feet are noticeably higher than your heart. Hold this for 20 minutes. Let gravity do the work. The fluid that has accumulated in the calves all day drains back into the central circulation while you are still awake and the kidneys are still active. The kidneys process it. You urinate it out by 7:30 or 8 p.m. You go to bed with legs that are genuinely empty. The 2 a.m. fluid shift cannot happen because there is no fluid left to shift. The timing is everything. Legs up at 9 p.m. does not work. The kidneys will not process the fluid before sleep. At 6 p.m., they will. Beverly started the 6 p.m. protocol on a Tuesday. She set a phone alarm labeled "Legs Up" and put it in her afternoon calendar, the same way she would a meeting. The first evening, she lay on her living room floor with her legs resting on the couch seat. She did not have a convenient wall, and spent 20 minutes there reading. She urinated at 7:15 p.m., which was earlier in the evening than usual. She noted this without giving it much weight. By the end of the first week, the morning pressure behind her eyes, the one she had described to her doctor as feeling like her head needed time to load, was noticeably lighter. By the end of the second week, it was gone most mornings. She called her doctor's office to mention it. The nurse noted it in the chart and said the doctor would be interested to hear it at her next appointment. The fluid that had been flowing back into Beverly's heart at 1 a.m. was now being processed by her kidneys at 7 p.m. and excreted before sleep. Her heart was going to bed with legs that were empty. The 2 a.m. volume surge had nowhere to come from. The third intervention addresses the renin panic from mild overnight hypoxia, and the research on it is specific and reproducible. The paranasal sinuses, the cavities behind your cheekbones, are the body's primary factory for nitric oxide gas. Nitric oxide is the signal molecule that tells blood vessel walls to relax and dilate. When you breathe through your nose, nitric oxide pools in the nasal cavity and is carried into the lungs with every breath, entering the bloodstream continuously. When the mouth falls open during sleep, that nitric oxide escapes into the room. The blood vessels lose their continuous relaxation signal. The narrowing airway, the slight oxygen drop, the renin response, all of it operates without the buffer of nasal nitric oxide. The research behind nasal breathing and nitric oxide is more extensive than most people realize. The discovery that the paranasal sinuses produce nitric oxide continuously, and that nasal breathing harvests this production while mouth breathing wastes it, emerged from work done in the 1990s that has been replicated consistently since. What makes it specifically relevant to reverse dipping is the timing. The worst of the nighttime oxygen fluctuations happen in the second and third hours of sleep, when the throat is most relaxed and the renin response is most likely to fire. Having the nitric oxide buffer operating continuously through those hours is the difference between a blood vessel that remains relaxed through minor hypoxic fluctuations and one that clamps down in response to them. The practical implementation is gentler than it sounds. A 1-inch strip of gentle surgical tape, the kind sold for wound care, not heavy-duty tape, placed horizontally across the lips is enough to discourage mouth opening without sealing them shut. The lips can still part slightly if needed. It is a nudge, not a seal. Most people adapt to it within 2 or 3 nights and report forgetting it is there by the end of the first week. If the idea is uncomfortable at first, practicing nasal breathing for 5 minutes before bed, the same 6 breaths per minute protocol that retrains the baroreceptors, prepares the airway and makes nasal-only breathing feel natural before the tape goes on. The fourth intervention is the one that sounds the simplest and delivers the most elegant chemistry. If the body spikes nighttime blood pressure to force stiffened kidneys to clear daytime sodium, the solution is to give the kidneys the fuel they need to clear that sodium during the day, so the nighttime spike is no longer necessary. Potassium is that fuel. It is the mineral that operates the intracellular pumps that move sodium out of the cell and out of the body through the urine. A dinner built around high potassium foods, avocado, spinach, salmon, sweet potato, loads the bloodstream with the exact mineral the kidneys need to clear the sodium from lunch before midnight. The kidneys have what they need. They process the sodium while you are still awake. By the time you go to sleep, the blood is clean. The body does not need to run the nighttime hydraulic pressure protocol because the sodium is already gone. The specifics matter here. The goal is not to supplement potassium. Potassium supplements carry the same risks as potassium-based salt substitutes in people on certain blood pressure medications, and the same warning about discussing with your doctor applies. The goal is food-form potassium, which is absorbed more gradually and processed more safely by the kidneys. A medium avocado contains roughly 700 milligrams of potassium. A cup of cooked spinach contains roughly 800 milligrams. A medium sweet potato contains around 540 milligrams. Salmon contains roughly 600 milligrams per serving. A dinner that includes any two of these comfortably delivers 1,200 to 1,500 milligrams of potassium, the volume that meaningfully loads the intracellular pumps in the kidney tubules to accelerate sodium clearance. This is not a permanent dietary restriction. It is a nightly loading strategy targeted at a specific biological problem. You are giving the kidneys the fuel they need before midnight, so the body does not have to raise blood pressure to force the work through during sleep. For seniors on ACE inhibitors or ARBs, who, as we have discussed, already have elevated potassium retention from their medication, speak with your doctor about your baseline potassium level before dramatically increasing dietary potassium. That conversation takes 60 seconds. It is worth having before changing the dinner consistently. This is not a diet, it is one meal, dinner. High potassium every evening, and the biochemical trigger for the most common cause of reverse dipping in seniors is removed. Now let me bring all 6 mechanisms together the way they actually operate in a senior's body, because understanding the compounding effect is what makes the protocol make sense. The delayed sodium excretion is the foundation. Because the aging kidneys cannot clear daytime sodium before sleep, the body is biochemically committed to a nighttime pressure elevation almost regardless of anything else. This is the baseline load. On top of it, the fluid shift adds volume. The fluid from the calves arrives in the bloodstream at the same time the kidney night shift pressure is building. The heart is now handling more volume at higher pressure simultaneously. The minor airway narrowing triggers renin. The renin cascade fires angiotensin II, which clamps the arteries on top of the volume and the kidney-driven pressure. The same 2 to 3 a.m. window is now carrying 3 simultaneous mechanisms. If a diuretic was taken in the morning, the aldosterone rebound fires at exactly this window. The medication that was counteracting sodium retention all day is gone. Aldosterone, unopposed, aggressively retains whatever sodium and water remain. The blood volume climbs further. And through all of this, if the cortisol rhythm is disrupted, which it is in a significant portion of seniors with chronic stress or insulin resistance, the sympathetic nervous system never fully released during sleep. The blood vessels are hyperreactive throughout. Every spike is amplified. 5 separate biological forces, all converging in the same 2-hour window, invisible to every daytime measurement, accumulating arterial damage night after night in a body whose chart says everything is under control. The 4 interventions in this protocol do not address one of these forces. They address all of them. The potassium dinner eliminates the biochemical trigger for the kidney night shift. The leg elevation removes the fluid that fuels the volume spike. The nasal breathing provides the nitric oxide buffer that dampens the renin response. And the chronotherapy shifts the medication peak to align with the window when it is needed most. Applied together, they interrupt the compounding. Applied individually, each one helps. Applied together, they change the report. If you want the complete picture, every mechanism, every intervention, the exact conversation to bring to your doctor, the protocol in the description below is what finally fixes your nights. The 4 interventions here, chronotherapy, the 6 p.m. leg elevation, nasal breathing, and the potassium dinner, address the root causes of nighttime blood pressure elevation specifically in seniors. Not the number, what is driving it. Before the summary, one thing worth saying directly. If you have been waking up at 2 or 3 a.m. to urinate for years and a doctor has attributed it entirely to your prostate or your bladder, Ask specifically about ambulatory blood pressure monitoring at your next appointment. It is a 24-hour cuff that records your blood pressure through the night. Most insurance covers it. Most cardiologists can order it. And if your nighttime readings show the reverse dipping pattern, you now know exactly what is causing each spike and exactly what addresses each one. Here is what to start tonight. Eat a high-potassium dinner. Avocado, spinach, salmon, sweet potato. Any combination. You are loading the fuel the kidneys need to clear today's sodium before midnight. At 6 p.m., not at bedtime, get into a recliner kicked all the way back or lie flat with 2 or 3 pillows stacked under your calves so your feet are higher than your heart. 20 minutes. The kidneys are still active at 6 p.m. and will process the fluid and excrete it before you sleep. At bedtime, use the mouth taping technique. A small vertical strip of gentle surgical tape over the center of the lips, a nudge, not a seal, to remind your body to breathe through your nose all night. The nitric oxide pools in the nasal cavity and keeps your blood vessels relaxed while you sleep. At your next doctor's appointment, bring up the Hygeia chronotherapy trial by name. Ask whether moving one of your blood pressure medications to bedtime is appropriate for your specific regimen. Ask for ambulatory blood pressure monitoring if you wake regularly in the night. Ask for your nighttime readings. They are the ones that matter. The thing Walter said when I think about this case, and I think about it often because his story is so representative of what happens to seniors with this pattern, is that the years of managing the daytime reading while the nighttime crisis ran unaddressed felt, in retrospect, like treating a fire by monitoring the smoke detector. The alarm looked fine. The readings looked fine. The fire was in the walls. Share this video with someone who wakes up every night at 3 a.m. and has been told for years it is just their bladder. They deserve to know what is actually happening. If this finally explains something you have been living with and nobody has ever named, leave a comment below and tell me. I read every one. The protocol is in the description. Your arteries have been working the night shift. Tonight, they get a chance to rest.